and today we're talking about who gets sick. So in a moment, I'm going to introduce the two guests that we have with us. We have two CEOs, sister CEOs. I get excited by that. But before we do that, we have a local artist who is amazing. And I'm sure many of you must have heard Ivory Doublet, who is a singer and an actor, and she is right now Twin Cities based, and she's a teaching artist at McPhail. We love McPhail. A number of our partner schools are partnered with McPhail, and she's performed at the Penumbra, the Chanhassen Dinner Theater, the Children's Theater, Theater Latte Da, many others. And her family performs as a gospel quartet, Save Thee. And she's performed with a number of other musical groups such as Soul Tight Committee Band and kid favorite, The Bazillions, which I've never heard of, but that means I'm old. So Ivory, welcome. And thank you for joining us, and thank you.
Thank you. Thanks for having me. I'm going to sing Down by the Riverside. You can clap along and even sing along. Gonna lay down my burdens down by the riverside, down by the riverside, down by the riverside. Gonna lay down my burdens down by the riverside and study no more. Well, I ain't gonna study no more. I ain't gonna study no more. Study no more. Well, I ain't gonna study no more. I ain't gonna study no more. Study no more. I'm gonna walk with the ones I love down by the riverside, down by the riverside, down by the riverside. I'm gonna walk with the ones I love down by the riverside and study no more. Well, I ain't gonna study no more. I ain't gonna study no more. Study no more. I ain't gonna study no more. I ain't gonna study no more. Study no more. Thank you for having me.
Ivory, thank you so much. That was absolutely beautiful. I love that. I told her Sam Cooke has a version of that, and my daddy used to sing it all the time. And it's so appropriate right now as we talk about peace and love and what we need most in our community. And so that's why it's so important that we have the two sister CEOs with us today. And I want to introduce them now as we talk about who gets sick. And so we have with us both Stella Whitney-West, who is the CEO of NorthPoint Health and Wellness Center. And NorthPoint is in the heart of North Minneapolis, and it's a federally qualified health center that serves over 25,000 residents in North Minneapolis and Hennepin County with comprehensive medical, dental, and behavioral health care. And Stella has been partnered with the Northside Achievement Zone for a long time. I love when NorthPoint, Stella, puts on your fun and fitness with Zumba classes and runs. And I mean, I just get so excited by that. But Stella has been a visionary in this community for a long time. And so Stella, welcome. I'm going to circle back to you in just a moment. And then after Stella introduces herself, you will hear from Andrea Walsh. And Andrea, I just so happen, I have to do a disclaimer, I am on her board. And I've been enjoying serving on HealthPartners board. She is the president and chief executive officer of Minnesota-based HealthPartners, and it is the largest consumer governed nonprofit healthcare organization in the nation. And so Stella and Andrea, welcome. And Stella, I want to start with you. If you could, three things. Tell us a little bit about who you are. You know, like we just see these, you are accomplished women. You are an accomplished woman. You lead a major institution. I think it's the largest on the North Side. And people just don't know you. Like, who are you? We just see lights. And then tell us some more about just kind of what led you to NorthPoint, and just a little bit more about NorthPoint.
Wow. Well, first of all, thank you, Sondra, for inviting me to participate in this SOAR North. I've been doing a lot of these. So when we talk about how are we going to be communicating going forward, this is going to be it. And I'm getting used to it, but I also miss the in-person. So there's a few of us around here because our clinic did not close. So we walk around. Normally I have my mask on. So when we're out in the public areas, even though there's in our administrative building, there's only 10 of us, we have our mask on. So I am a native Minnesotan, born and raised in St. Paul, the Rondo neighborhood of St. Paul. Grew up there. I grew up in a community that was predominantly African American. A lot of people that are not from here are always surprised, like, what? Yes, when I grew up in the Rondo neighborhood. I went to McKinley Elementary School, which was predominantly Black, but we had mostly white teachers. I remember when we got our first Black teacher, Mr. Zachary, and how we were all really in awe of him. And he was very strict and wanted nothing but excellence from us. And I'm really grateful for that upbringing. We grew up in neighborhoods where we played outside till the street lights came on. And it was that level of comfort where the parents took care of other children. Sometimes we didn't know who we belonged to or whose table we were going to be sitting at for dinner. And then I graduated University of Minnesota with a bachelor's in biology and minored in chemistry, and have an MBA from the University of St. Thomas. I initially went into corporate. So I worked for the old Pillsbury company, did research there for a number of years, worked at the University of Minnesota, did research. But I was never really completely satisfied. I was married at the time and had 4 children, 1 biological, 4 that I adopted as my own, and wanted to work in my community. So I left my job at Pillsbury, took a big, huge pay cut, and started working for the Minneapolis Urban League in health education. And back then, we did a lot. It was during the HIV/AIDS crisis. And we did a lot of street outreach. We did a lot of work the old-fashioned way. We used to have home visits where we would talk with people and families about the impact of HIV. And so I've always worked after the Urban League in a variety of different nonprofits. I worked at one time for the United Way. I worked actually for the St. Paul United Way, and was there when they merged to become the Twin Cities, the Greater Twin Cities United Way. And then actually went back to the Urban League, and at the time, Pilot City under Gary Cunningham was merging, right? And so he asked me to come over and to be the Chief Operations Officer of the Human Services. And so I did that. And he had told me at the time that he wanted me to be prepared to be the CEO. And I had told him, this is a quote, never gonna happen, because here's why. Because that meant I would have to be a Hennepin County employee. And I said, not interested in working for the county. But long story short, right, but NorthPoint and the position that I have and as an FQHC, we are in partnership with Hennepin County. So I actually report to the Community Board of Directors. And we're 51%, actually higher than that. Over 60% of our board members are actual patients. They live or work in this community. It's a requirement. And that's why I love the community health center model, because the people that are my bosses are the patients or the community. That's who I report to. I happen to be a Hennepin County employee because that is part of the HR system that we operate under. And NorthPoint is the largest community health center in Hennepin County. We're the second largest in the state of Minnesota. There are 17 across the state. We're in urban as well as rural areas. So, in addition to, as you mentioned, medical, dental, behavioral health, we have an on-site pharmacy. We also have laboratory, radiology. So we are a fairly sophisticated, large community health center. And I love my job. I love the work that I do here. So I'm a mother, I'm a grandmother, I'm an auntie, I'm a cousin. I am a product of Minnesota, of the Rondo neighborhood. That's who I am.
Thank you so much. Now, Stella, we worked together for years. I didn't know that. Like, I feel like, was I under a rock or what? So thank you for sharing. And, you know, being consumer-led, like the patients really leading is something you have in common with Andrea in terms of HealthPartners, because I've been a patient of HealthPartners for over 20 years when I worked for Ford Motor Company. And so I know I bring that perspective to the board. But so Andrea, welcome, and tell us a little bit about you and a little bit more about HealthPartners.
Thanks, Sondra. And I just want to start off by saying how delighted I am to be with both of you, Sondra and Stella. It's fantastic, and actually I think there are no degrees of separation between us. As I was listening, Stella, to your description of NorthPoint and the important work going on in the community, I was reflecting on exactly the point you made, Sondra, which is HealthPartners, like NorthPoint, we're a consumer-governed organization, and what that means to us is that our board of directors consists of people who carry a HealthPartners insurance card or get care from our delivery system, which spans the greater Twin Cities area. We actually have a history. We got our start as an organization as a co-op. Our founders came together with the idea that access to healthcare only happens if you have insurance to go with it. So we have forever been both a care delivery system and a HealthPartners and a health insurance company. And that's what's unique about us, is both that notion of care delivery and health plan together. And then the other thing unique is our consumer governed board. So Sondra is on our board as a result of being successful in a contested election, running for our board of directors. We have long held as one of the most important things we can do from a governance standpoint is to have our board reflect the communities we serve. Stella, actually, you might be interested to know that Willie Mae Wilson was on our HealthPartners board for years. Actually, I joined HealthPartners about 25 years ago, and she came onto the board in that era. And actually, part of our passion and our commitment to health equity is as a result, a direct result of Willie Mae Wilson and her voice in our boardroom as it relates to how can we do a better job serving the community, the entire community, and how do we make sure that every person in our community gets not only access to great health care, but access to great health and all that surrounds it. So I'm delighted to be here today and have a chance to share a little bit about what's going on at HealthPartners. As far as an introduction to me, I've been at HealthPartners, as I mentioned, for 5 years. I am a mom. I've got 3 grown children, 2 boys and a daughter. My oldest son is married, and he and his wife are about to have a baby in July. So I'm nearly a grandmother, not quite there. I'm a grandparent to 2 dogs, if that counts. So grand dogs, which is great. I grew up in Rochester. I was born actually in Kansas City, and my parents moved up to. My dad was in his medical school residency program. He was a physician at Mayo throughout his career. So I spent my childhood in Rochester for the most part. We moved when he was drafted and was in the service out in California. We came back. I graduated from high school in Rochester and then went on to college and ultimately law school. I've spent my whole professional career here in the Twin Cities community. I have both practiced law as a lawyer in 2 different law firms. I have a passion around community health and public health. I was privileged to serve as an assistant commissioner in the health department in the early 90s when Minnesota Care passed. And then came to work at HealthPartners shortly thereafter, and has really spent my career at HealthPartners focused not only on how can we provide access to great care and great health insurance, but what can we do in the community? How can we partner effectively to make sure that we bring our best to the communities that we serve? So it's great to be here today, and I look forward to the dialogue.
Oh, thank you. Thanks to both of you for being here. So I want to jump right in and start with showing a heat map. And Andrea, you had sent this in. There's a CDC heat map that we've all been looking at these days of the Twin Cities, and I know they have it of different areas, but this is one that highlights the various risk factors and neighborhood and community level risk factors. And it's for both Minneapolis and St. Paul. You can see Minneapolis there on the left. And as you can see, when you look at all of the risk factors together, and I know on another slide that you had, Andrea, it showed that North Minneapolis has from 3 to 7 based on asthma, COPD, heart disease, kidney disease, diabetes, obesity, stroke, all of the tabs that are at the bottom. But you can, yes, thank you. So you can see where the 3 to 7 risk factors is where the red is, 1 to 2, and then none. And so disproportionately for this community, as well as places over south, just looking at Minneapolis, our community is threatened. And it's not unlike what's happening around the country. And so I definitely want to get into that. And so this is one of the reasons why I asked you all here, because you are leading health in our city and in our state and in our county. So you're perfect ones to talk about this. So I want to start off though and kind of pull it up a little bit more and ask Andrea, I'll start with you. When did HealthPartners first start talking about the virus? And because it feels like it was like overnight. And then can you lay out what you know about it? Kind of any like the facts from fiction.
Sure. Yeah. So actually, it was just back in January, which now seems like an eternity ago, when we thought over in our Park Nicollet clinic in Methodist Hospital that we had a patient who had COVID. And so that was the point in time where across our entire system, we really started screening people for the symptoms of COVID. And the challenge has been that, COVID, it's a global phenomenon. It's in every community, every place across the world. And we've watched and learned how infectious it is, how easy it is to become infected with COVID. And then we've also watched, more importantly, at who's most likely to be at risk to get really sick if you get infected. So COVID initially looked like it might be like flu-like symptoms, like a cold and sore throat, upper respiratory junk, kind of that chronic, runny sore throat, runny nose, just feeling cruddy, fever, chills. The challenge is for as we look across the population, people who get infected with COVID and get the disease, about 80% of us do okay with it. 20% are not going to do okay with it. And of that 3 to 5%, it may become deadly for. And that map that you pointed out, Sondra, is so important, because what we are learning since January, in the months as we've watched what's gone on in New York, what's gone on in New Orleans, what's gone on in communities across our country, is that communities that have other chronic illness and disease are more likely to have people get sick with COVID and not do well, end up in the hospital, end up on a ventilator, end up dying as a result of getting what seems at first like just an upper respiratory crud. And so the things that make people more at risk are obesity, diabetes, coronary artery disease, chronic lung disease, chronic diseases. And the reality is that disproportionately, those folks at highest risk that have those chronic illness and diseases are also predominantly more likely in our communities of color. So we have higher incidence of diabetes, coronary artery disease, and obesity in communities of color. We have more risk there. And so we need to pay particular attention to what can we do as a community to make sure we protect our people and our communities from getting infected.
Now, thank you, Andrea. So statewide right now, I know our numbers don't look like the rest of the country.
Yeah.
So right now in our state, who's getting sick statewide?
Yeah, it's interesting. They're statewide right now, where there's been a lot of focus is in congregate living. So think nursing homes, assisted living, the elderly, and the elderly are definitely at risk for getting COVID. And part of it is living in close quarters. Part of it is age, and with age comes some of those chronic illness and disease that make you more susceptible to the illness. The other communities where we've seen a disproportionate impact is in the turkey and meat plant, the meat plants, meat processing plants in greater Minnesota. And there you see how quickly it can spread in workplaces where people are close together. And I think one of the things that is worth talking about this afternoon is the fact that in low income communities, we have greater risk. Where you are living together in smaller rooms, where you are taking public transportation, where you're unable to get access to masks, where you don't have access to disinfectant wipes or are using public toilets regularly, where you're unable to miss work, there is a greater likelihood that there will be the spread of the illness. So I think we as a community want to make sure that we get out front of that and help share with people what you can do to prevent getting it in the first place, and what you can do if you get it to isolate and stay away from other people so that we don't spread it.
Yeah, absolutely.
And Stella, you probably are seeing that in the community as well.
Yeah, yes, we are. And if I can just add to what Andrea is saying, is that I think one other thing that we noticed in Minnesota, and particularly if you look at who gets infected, and you look at the age range, it is really the younger age range where you see the infections. So this is data. We do a daily huddle with our staff, and we show this data. So for the state of Minnesota, you look at the age between 20 to 49, that group is the highest percent of the folks that get infected. But in terms of the folks that end up dying, you're right, is those that are in those long-term congregate living, the nursing homes, the elderly, who are the ones who are ending up where COVID causes the death. And I think it's because of all of those factors that their immune systems are not strong, and they have a lot of underlying health conditions. But also when you look at the fact that, and we always see that in the flu season, right? The nursing homes and the elderly are the ones who are dying from the flu. So that is pretty much the same that we're seeing with this coronavirus. But this is very, you're right, the high degree of infection, and I think because it's what they call the novel virus, we're still learning, because I remember when we first started screening our patients by the symptoms, we had to add the symptom, which was the one of the loss of taste and smell.
Yeah.
Because that came on later. And in fact, I remember we had a patient that screened perfectly. And then when she got into the exam room with the provider, she started complaining about that she had lost her sense of taste and smell. The provider at that time, because we were separating, if you were high risk and you screened that you might likely have COVID, we put you in isolation and we did the testing. She, on the other hand, had passed the screening, right? But it was the provider that said, you know, I think I had read something about this. I'm going to make sure that you get tested. She got tested and she was positive. And then shortly after was when they started changing those guidelines around those symptoms for that. So.
Yeah. I think the other interesting thing we've been seeing in clinic, and Stella's exactly right, the elderly definitely have a higher likelihood of ending up very sick and in the hospital and oftentimes not recovering. The other thing that is in that, the age range of 20 to 49, is if you do have chronic illness and disease, so diabetes or obesity or stroke, you may get it and you may do fine the first week, and in the second week, your body, what happens is your lungs actually fill with fluid as your body tries to fight the infection, and that filling of fluid causes people who are seemingly otherwise pretty healthy, they may have a chronic disease or illness, but are pretty much day in, day out, otherwise healthy, just crash. And so while the numbers aren't as high, I think part of the message and part of the importance of the physical distancing, the wearing the mask, taking steps in the community is you may be walking around perfectly healthy and you may be one of those statistics that ends up, you may end up being part of that statistic that we don't know why, but you don't do well, you end up sicker. And if you have chronic illness and disease, the likelihood is just greater.
Yeah.
Correct.
So,
And
Stella,
I know
what are
people,
you saying? No, I'm sorry. Stella, what are you seeing on the ground here? Like when did NorthPoint, when did you start seeing, I know Andrea said the first case was in January at HealthPartners. When did you start saying, uh-oh? And then what is NorthPoint doing on the ground right now?
So for us, it was really around late December, probably mid-January. Mm-hmm. And what was a signal for us was that our PPE, personal protective equipment, so masks and gowns and gloves, our orders were not being filled. And we were getting the notice from the suppliers that there was a disruption in the supply chain, because we knew that there was the outbreak in China. Yeah. And that was the first sign that we got, was that the disruption in the supply chain, and we could not get these the personal protective equipment, which I think just about everybody knows what PPE is now, and how critical that was. So we began to start asking other county departments, were they having trouble? And of course, within the county, outside of the hospital, most people don't realize that Hennepin Healthcare, formerly HCMC, who was a county department, is now independent, but still connected with the county. So we, as a clinic, connected with the county, see more patients. And so the other departments weren't having the problem that we initially did. And then we started, of course, as Andrea said, is that started to see patients that were coming in. And then, of course, I think everybody started around late February, early March, where we just had to. I mean, the numbers were there. We had to start isolating people, testing. So I remember when, as part of Hennepin County, it was like that second week in March. I think the emergency was declared around March 16th or somewhere around there. But a week before then, we started pulling out. So, you know, we had what we call continuity of operations plan, and things that we would do in the event of a disaster or a pandemic. We started pulling those plans out, and through the county started forming what they call an incident command structure, because we knew then that we were going to have to operate differently. And so we had to become aware of what our plans were, how we were going to stay open, because we were considered an essential provider, all healthcare. But even beyond that, I think people forget that essential providers are pretty much those frontline folks. So a lot of police, firefighters. I think about the people who are working in the nursing homes. We talk about the patients in the nursing homes, but one of the first group of patients that we were seeing that were coming in infected were those workers in those nursing homes, and those were predominantly workers of color. They were the lower wage earners, but were exposed.
Yes.
And it was really heartbreaking. And the difficulty was providing that message that now you were infected. And I remember early on, and you probably remember this too, Andrea, and maybe you didn't have that at HealthPartners. Initially, when we were doing our testing, we were sending it to the Department of Health.
Right.
Because we were just doing the collection of the samples, right? And it was taking a week or more to get the results. Mm-hmm. Well, if somebody is positive, you know, we pretty much were able to, according to their symptoms, we said, well, that they were presumptive positive.
Okay.
But people really needed to know and wanted to know. Now we're able to get results back within 24 hours because of the connection, because HCMC runs our tests now. We get them back in 24 hours pretty soon. And my lab director told me, please don't announce it, but I'm not going to announce it. But we're working on being able to run those tests ourselves within our own laboratory and to be able to get those results within an hour.
Well,
I think one of the I'm sorry.
I'm sorry, and I'm going to jump to you, Andrea. I want to get to the testing. So, because, you know, my experience over North, and I think it was happening everywhere. Because at first I thought, they're not testing Black people. I'm going to just tell you the truth, right? Because it was people walking around. It was like, they definitely have it, but they couldn't get tested. But that was also happening to white people and to Asian people. Like, it was across the board, so little testing happening. But that's changed. And so, you know, Stella, I wanted to, so right now, who's being tested on the North side? And then, Andrea, I want to hear from you as well. Because at one point, it just wasn't happening for folks.
Well, and I think I can tell you about who we are testing.
Yes.
And so we are testing predominantly African Americans and Latinos. So NorthPoint first started doing testing within our clinic. And then we realized that we needed to expand, we needed to do more. And so we came up with that we would do the drive-through testing, not the drive-up. So we have a parking ramp that we have been using for our testing. And we opened that up in April. And so as soon as we started that, the numbers started. So in our clinic, we can maximum test 15, maybe 20 people a day. With our drive-through clinic, we can test up to 80 a day through there. And so we have done over 700, and actually this is from, I want to say Friday. We've tested over 779. I'm going to look at my data real quick. And of that, over 200 were positive. But when we look at, and you talk about the disparity, what we found is that of the people that got tested, 38% were African American, and 38% were Latino. But when we looked at what percent were positive, for African Americans, it was 38%. So we tested 38% were positive. For Latinos, there was a huge disparity. 47% were positive. So that was a wake-up call for us. But 30% of NorthPoint's patients, so we serve over 28,000 patients, and 30% are Latino. We've seen the fastest growth in our Latino population. Over 50% of our patients are African American, and 11% are Southeast Asian, predominantly Hmong.
Okay.
So,
got it. And Andrea, what about you with HealthPartners?
Yeah. So yeah, I think the interesting thing is just how fast testing has accelerated. So Stella and I think HealthPartners, both of our organizations, in the early part, in January and February, we were in this watching mode. And I think March 6th was when Minnesota had the first case of COVID. And so it's like you think about what's happened in this community from March 6th until today, May 19, a lot. And we have been challenged as a community because of the lack of testing supplies. And so we know there's been a greater need for testing than there have been supplies. So there have been shortages of personal protective equipment, the PPE that Stella mentioned, but the testing supplies have been also in short supply. So all of the healthcare systems have been looking at how do we test limited populations, and the populations that we began testing were initially people who were sick in the hospital, because we needed to know for their own health and for the health of the care teams. We began testing healthcare workers and first responders, essential workers, because obviously we want to make sure that our essential workers and our healthcare teams are healthy and not spreading disease to patients and to the community. And up until just like almost 3 weeks ago now, the common refrain, I think, for all of us across the community was, if you have the symptoms, if you've got a dry cough and a fever, if you can't taste and smell, assume you have COVID and stay home. Don't come get a test, because we don't have tests to give you. And it wasn't because folks didn't want to test. It was the reality of there's no supplies, and the supplies are a nasal swab to actually do the test, administer the test, collected, and then the testing kits for the labs to use. So a couple of weeks ago, the governor announced a statewide testing vision to get to a point where we could test across the state 20,000 people. At HealthPartners, we took that goal and said, you know what, let's take 10%. Let's get our numbers to 2,000. Let's get to a place where we can test 2,000 people a day across the greater Twin Cities. Let's reach our patients. And we stood up 8 drive-through testing sites, as well as we had 4 respiratory care centers where we reconfigured primary care clinics and said, gosh, for our patients who have any respiratory care symptoms, let's send them, let's have those patients go to respiratory care centers so that we can keep our other clinics open and available for folks who don't have that illness but have other healthcare needs. So we are today, on average in the last week and a half, testing somewhere between 1,000 and 1,600 people a day across our system. We are keeping track. We keep track of the ethnic background, the diversity of our patients as we're testing. Right now, our tests appear to track the general proportion of the population, but we are very keenly aware of wanting to make sure, to Stella's point, that we understand are our African American communities seeing higher levels of COVID exposure and illness, and then and beyond that, given some of the risk factors, are we seeing more of our African American and Latino patients in the hospital and in ICUs because of greater illness, disease, and burden? At this point, it's just too early to tell because we're basically a couple of weeks in, but we are literally in our hospital incident command and in our health system incident command looking at who are we testing, what are the results, and then who's in the hospital and how are they doing in the hospital and what's the outcome, with the goal of how do we help people move through the illness and get to the healthier other side.
Right, absolutely.
Right.
That's the thing that we really want to guard for as well. You know, many of us got really scared when we heard the governor say, you know, we're reopening the economy, you know, let's get back to work, you know, we're doing it in a measured, you know, way. But for our community, it's like, okay, it's on now. Everything back to normal. When the infection rate, the disparities, what I'm hearing you two say is we haven't been seeing that in the same way you're seeing it in Chicago and in New York and so on. So we have like 15 minutes left. Can you believe it? What I want to ask is two things. One, and Stella, let's start with you. Why are communities of color being more impacted? Like, what are the reasons? We talked some about it, but I want to hear, like, what are some of the reasons? Talk about some of the social determinants of health. And then I want to specifically close with what you all are doing in your healthcare institutions and what can be done so that we stop the spread. Like, we really want to stop the spread. So Stella, so why the disproportionality when it comes to Black and brown folks?
Well, and in addition to the heat map that talks about the underlying health conditions, but I say also that the cause for many of those underlying health conditions are what you just said, those social determinants. And I say not only social determinants, but political determinants of health, where people live, how people are able to make or not make a living. All of those conditions lead to poor health outcomes. If you are not able to afford decent housing or housing at all, I mean, I don't know how many, I mean, I'm sure we've all seen and read in the paper the homelessness, the encampments that are coming up. So if you think about a virus like the coronavirus, that is a choice condition for that virus to spread. You've got people who are, because of their economic conditions, are living in crowded housing, you know, trying to make ends meet. You talk about low wage workers who don't have sick leave, or if they have any, they're saving it because if a child gets sick, they know that they're going to have to take off work to take care of that child. Then you've got people who are going to work out of necessity sick, because they can't afford to lose their job. So all of those conditions lead to those poor health outcomes. And I have always said that, and we see it, and I know Andrea sees it, is that to be able to afford, and in Minnesota, we've been fortunate because we were one of the first states under the Obamacare to expand Medicaid and to make sure that low income people got access to health care. But even with that, it is still expensive when you look at the pharmaceuticals. And thank God Minnesota passed the law in the legislature to make insulin more affordable. But the fact is that to know that a life-saving drug like insulin was out of reach for so many people, and people died because they could not afford it.
Yes.
So that's a major cause.
And I do think the worrisome thing is that we're just still in the really early days of this pandemic, and so I think we need to really make sure that we do everything we can in our communities, and particularly in our communities of color, to help address the challenges that families face as they look and try to balance what to do with kids home in a school, with work that is no longer there, or that work that is there and you can't afford to be sick. We've got a lot of issues that need to be addressed, and I think not the least of which is we keep learning all these new things about COVID-19, and so it's hard for people to keep up with what's real and what's myth. Is it important to wear a mask? How important is washing your hands? Does it matter? What is this social distancing thing? And all of this, I mean, you think about what's so important in community, and the fabric of great communities is social connection. And so much of what has to happen during this time is creating physical distancing and changing the ways we operate. So some of the very supportive structures that we put in place to help people, we're having to break those cycles. I think about for NAS, the really important work you do with your scholars and with your families, and how you've had to just overnight literally change that. And you know, how do we help families cope over the next several months and stay attuned to the very real risk of catching this virus and ending up, you know, in a bad spot.
Exactly.
So that's how I want to close. In fact, Andrea, let's start with you, and then Stella will close with you. What is HealthPartners doing? If you could hold up a couple things, and
Sure.
specifically around addressing the disproportionality of this disease, that again, we haven't even seen it hit the cities like it's poised to. So, so what are you all doing? What can we do to stem the tide? And then Stella, I'm going to ask you the same thing.
So maybe just 4 quick things. One is education and outreach. How can we reach people, share what we know, and share what we're learning? The second thing is collecting data. We need to know where we stand on race, ethnicity, country of origin, so we can better understand who's getting sick and how do we help support and restore health. So that's the second thing, and it's really important. The third is interpreter services. How do we reach out to communities and help particularly our patients where English is a second language, or maybe English isn't even a language that's reachable in the household? And so we really are paying attention to our interpreter services and what role can we play there. And then fourth and final, I would just say little moments count, and all of our work in the community to reach young families in particular. I worry a lot about COVID spreading, and I worry just as much about measles. I'm really worried that the next epidemic that's coming is measles, because families aren't taking their 0 to 2-year-olds in for immunizations. 5 and 6-year-olds aren't getting the shots they need. And measles is actually way more contagious than COVID-19. And so, you know, a child with measles, I think the statistic is spreads on average that single measles case to 18 different people. So you think about what could happen in the North community with the measles outbreak. We've got to get kids in and get immunizations to happen. And I think that's got to be our top priority this summer.
Yeah, thank you. And Stella, are you seeing the same thing? What are you you all focused on?
So we are seeing the same thing as well, and it's one that, in fact, we talked about with our board meeting and our board briefing, is that, and our medical director quoted that 70% drop in the number of kids who are not being immunized. And Andrea is right. It wasn't too long ago that Minnesota had that outbreak of
Right.
measles, and how difficult that would be. And so, but there's a fear and anxiety. Our behavioral health specialists and our behavioral health staff, they're doing telehealth. And that was new for us. And yet we know that going forward, that is going to be a major piece of how we do our work. Many of our patients were so relieved that they were getting a phone call, that there was someone they could talk to about their anxiety, about their fear, and afraid to even come into the clinic because they were afraid that they may become infected. They didn't want to bring their child in because they weren't sure, you know, why am I going to bring my child in when you're treating all of these folks who have the virus? And so being able to have that conversation with them, and actually I was just talking with our communications director, and we were saying, how are we going to reach out to our patients and show them these are the things that we're doing to protect you? Things like screening all of the people. We screen our employees before they come in, wiping down the surfaces, making sure that there's hand sanitizer, making sure that people have masks, making sure, and we give out masks to our patients and tell them, you know, make sure that you are wearing a mask when you're in the community. We've done distribution of cloth masks as well. And through our food shelf, we're distributing masks because we want to make sure that people understand that when you are wearing a mask and the people that you are associated with are wearing a mask, that's how you're going to disrupt the transmission. And I think another thing to add, because of the statewide focus on increasing the testing, there's also the statewide focus on which it needs to be on the what they call the case investigation and contact tracing. So what we've done here at NorthPoint is that we call all of our positives and we call all of the negatives. And the reason that we do that is around the education. Because and actually we start when you come in for a test. You get a packet of information of numbers that you can call, and we remind people, just because you're negative today does not mean that tomorrow or next week, and we're saying this is what you need to do. You also need to be checking and making sure, aware of any symptoms. If you're getting any symptoms, come back.
Yeah.
You can get tested, but you should also make sure that you know washing your hands. Soap and water. We tell people, because when there wasn't any, there's still a low amount of hand sanitizer, good old-fashioned cheap soap and water disrupts this virus. You can do that.
And is actually better.
Better.
Yeah.
Absolutely better.
I want to ask about the telemedicine, because that's when we had moms on 2 weeks ago, and they all talked about increased anxiety, increased depression, largely a Black group of moms. Stella, you mentioned the telehealth medicine. Andrea, you all are doing it as well.
Yeah, so we are doing video visits. We're doing phone visits as well, but what's really taken off is video visits. So we've done about 70,000 video visits in the last month. And it's been in primary care, across specialty care, and it's been especially well received for mental health visits. In fact, we saw as many patients for mental health visits via video as we did in person the month prior, meaning that we've been able to provide continued good access to mental health services via video when we couldn't have patients come in physically. So we're looking as we move forward about how do we continue to wire that, because we know families have told us for a long time, don't waste my time. Don't make me come in midday. And I've got three, and especially if I've got 3 kids, I don't want all 4 of us to need to show up. So video visit has been a phenomenal way for us to reach families. I think what we have to figure out is those shots, those immunizations. How do we, because we can't do that over video. So we're reaching out, I think we're in the process now of proactively reaching out to families with reminders. You're overdue. Bring your kids in. And I think to Stella's earlier point, we just need to build confidence, restore confidence in the community that a clinic and a hospital is actually a safe place to go. If you're sick or you need a wellness visit, you need to come back in. And I think that falls on us to build that trust.
Yes, it does.
And it actually falls on all of us now, because you all are talking about the livelihood of this community, this city, this state, right? Of being able to keep our people alive.
Right.
And again, I'm so concerned about the communities that are the hot spots. I want to thank you both for being here. You are leaders in this. You were leaders before this pandemic, and I'm so happy you're flying the airplane right now. And we need to be able to have confidence and join with you around what you need us to do, those of us who are on the ground. And Stella, I know you're on the, both of you are on the ground. Stella's here in community, but what do you need community leaders to do to get the word out, to let people know? And I just want to thank you. I'm going to close with a quote and an invitation for the rest of you to, I know you're as excited about Stella and Andrea's leadership as I am. And when you get a chance, tell them thank you. And all of the healthcare workers who are taking care of us right now. I hear that JFK talked about how the Chinese people, the word for crisis and how they write it. And he said the way Chinese write the word crisis is they use 2 strokes. And he said 1 stroke means danger and the other stroke means opportunity. And in the midst of this, that is really what we're facing right now. Intense danger, particularly for the communities with the most risk factors, but also intense opportunities, particularly for the communities with the most risk factors. If, like Stella said, we can address the social determinants of health and the political determinants that have created the conditions with which people of color and low income people are more sick. It has been by design. So everybody join us next time. We are on May 27th, 3:30 again, going to have our next Soar North. And that is entitled Teachable Moments. So we had parents on, we had 2 healthcare leaders in our state, and the next time we're gonna have our educational leaders, our teachers. Nice. And we're gonna talk to them around what they're experiencing, what their challenges are, but also their opportunities and how we can all lean in. Thank you for joining us, Stella.
Thank you, Sondra.
Thank you.
Thank you, Andrea. This was great.
Yeah, good to see you again.
Bye-bye, everybody. Thank you for
Bye-bye.
Love your neighbor, wear your mask.
Oh, amen to that.
Thank you.